Okay, we will get going. Welcome, everybody. Last chunk of material. I feel like it's going to be a whirlwind of infectious disease. There are 6 chapters left that cover respective body sites as we move through here, and technically 6 lectures left. So my hopes are to basically bust out a chapter a day and give you a pretty good overview of some of the microbes that we see potentially plaguing some of these body sites. There are a handful of organisms that we may potentially see repeated in some of these chapters because some of them have potentials to be infectious at multiple body sites. There are lots of players as we move through here. And a key thing that I would like to kind of point out is each of the groups, so bacteria and virus, fungi, and smattering of some parasites, they each have some sections in each of these chapters and some tables that put them into some perspective. And it's the tables that really, when it comes time to thinking about exam stuff, that's what I recommend you kind of focus on. I'm going to be pulling lots of questions kind of related to that. Body site, respective organism, some of the symptoms, stuff like that are what we kind of want to think about. So for the final, it only covers this new material. So these last 6 chapters, which does seem like a plethora of stuff, but it will be like all of the other tests. My intentions are to get it opened not this Friday, but next, and have it open until whatever the date is that the final is supposed to happen in person. I want to say that's Thursday of finals, but maybe it's Wednesday, one of those days. And it'll close at 5 p.m. just like all of the others, even though it says 7:30 to 9:30. That's just final exam schedule based off of this class time. All right. So you've got time just like all of the others. So before I jump into this, questions, concerns? Hopefully all good. All right. So the first bit of material as we move through here really kind of makes sense. We want to think about our skin. As we described before with some of the immunology, with the innate response, the skin really provides a pretty good barrier against things that we may be coming in contact with. And if it's nice and intact and not wounded, unbroken skin, pretty good barrier. But then there are potentials for things to make it through those defenses or to colonize and potentially set the stage for infection. So we will move through and think about all sorts of culprits with this. And I am going to try to keep it at a pretty quick pace as we move through here and not get bogged down with lots of these images, although there are a few that I'm just like, oh man. Initially looking at the skin and teenager in this image is what I am assuming. Acne is something that's a common occurrence with many as we start thinking about teenage years or reflecting upon those years, and oftentimes kind of plagued with some of these issues. So folliculitis is our first bit, the inflammation of hair follicles, and then the acne lesion as we see more of that similar folliculitis inflammation of follicles as well. And in this case, we can see bacteria thriving in a really lipid-rich environment as we think about moving into puberty, all sorts of changes start occurring and more oily secretions start being deposited, and that becomes a breeding ground for some organisms to colonize and potentially lend to some of these issues. We'll get back to some acne in a bit and some of the culprits with that. We've seen some images of this before. I'm not going to get bogged down with the different anatomy as we start thinking about the skin, but there are multiple potentials for organisms to colonize on the epidermis, to move deeper in as we think about some potential pathogens, hair follicles, and pores, also opportunities to see some organisms. So this image kind of makes me think back to when we showed the image of the person's car and swabbing all sorts of different points where we could see things. It also makes me think about your first lab when you swab things in the building, trying to see what sorts of stuff was there. Thoughts could also be about what could I potentially colonize? And previous to COVID, we did a handful of labs at the end that were like bacteria of the body, and we do some skin swabbing just to kind of see what sorts of things might we colonize. And we used a couple of different types of plates. One that we've seen before, and we'll see again, the mannitol salt agar plate or MSA plate to get some Staph aureus growing. But we also use some Sabarode plates, which are a special type of plate for fungi. Thinking maybe finding some athlete's foot or something like that, where you could maybe get some fungus growing on some of these plates. And then other plates, dependent upon what we were looking at, but maybe some blood agar plates and throat swabs and whatever, to kind of give you an overview of what you got going on. And that's really what this kind of points at as we look at this. All sorts of different areas that were evaluated. And it also makes me think of things like the microbiome project, where we think about all sorts of organisms in us and on us, helping to keep us healthy or potentially to cause some disease. So we've got all of these little pie charts, color coding respective groups of bacteria, not narrowing down to the specific type of bacterium, but giving us some ideas about who we might see. And really, as we look at our body, we could think of it kind of like an ecosystem where we've got all sorts of different types of habitats. Some areas more arid, some maybe a little more moist or oily, different areas, environments where different types of organisms might say, this is perfect, right? So we could see a smattering of different types living on places on our body. And this just, again, thinking skin. So back to some acne, we can see some images of what's happening, and we're going to go through and look at some potentials for types of lesions that we might see on our skin in the first place. So here we could see this whitehead, this pus-filled lesion, and that's what we're looking at right there. There are other potentials where we may see some oxidation occurring and some blackheads. I think that's coming up shortly. So these different types of lesions, from crusts, kind of scab-like as we look at this, to ulcers and vesicles, all sorts of different potentials, and again, kind of dependent upon where we are at specifically within the layers of the skin that we may be seeing some of these respective lesions. And we'll see some of that as we progress through here. So we're going to think about the eye a little bit as we move through here. And, you know, it's sometimes there are things that we're like, well, where do we actually place this? The eye could potentially be, grouped up with the nervous system, and we could think about some of that. There's definitely potentials for that, but it also has the potential to have some exposure to the outside world with the conjunctiva and potentially some organisms living on our skin, maybe colonizing that. And so the question might be, well, where do we really put it? And we've got it with skin infections. There are other ideas with, some things are like, well, where should we talk about this organism or that? Well, it kind of just depends, right? So here we go. All right. So the eye has numerous things that we may think about as lending to some protection against coming in contact with things. And there's also possibilities maybe for lacrimal glands or ducts to get inflamed, blocked, or infected, lending to other issues. And we'll see some potentials with some of this in a second. So, like I said, the conjunctiva potentially may be colonized with some organisms, but as we move to the inside, the vitreous humor, this should be sterile, all right? Doesn't mean that it always is. There are some potentials for things to get in there and cause some serious damage, and we'll hit some of that toward the tail end of this chapter as we think about some potential parasites causing problems. So this image, and as I opened it up this morning and scrolled through quickly, it's always something that I find just a little bit disturbing. I don't know. And I don't know which of the three really is the most disturbing. They're all kind of equally. The first one is some conjunctivitis. So inflammation of the conjunctiva. You can see some pus within here. Lots of redness, inflammation, right? Blepharitis is inflammation of the eyelids. And I'm like, well, of course, look how you're pulling on those suckers, right? You're just begging for some inflammation. This poor individual, I want to say poor kid, but I don't know for sure. And then keratitis, so inflammation of the cornea. There are a handful of culprits that might cause some issues with this and maybe potentially lending to some blindness. This was a couple of semesters back, but I still mention it because I think it's kind of funny. When I was first lecturing in this text and moving through here, talking about this stuff, I'm like, look at this person's eye. It looks like they've seen a ghost, right? That's what I imagined, right? And then I'm like, wait a minute, maybe this person's seeing something too. There's another image a little bit down the road, similar thing. And I'm like, wait a minute, that's just a reflection. It's not a ghost, right? But it could be, right? All right, and maybe deep down, that's what I found so disturbing was the ghost in the eye, right? Okay, so here's some Staphylococcus. We have seen some of these, probably both of these bacteria growing on some MSA. I'm pretty sure you have. So the mannitol salt agar initially is red. And then if the bacteria has the potential to ferment the sugar mannitol, it turns the medium yellow. And so on one half of the plate, we've got our Staphylococcus aureus that ferments it. And on the other side of the plate is Staphylococcus epidermidis, a cousin, and it doesn't ferment mannitol. So this plate allows us to quickly differentiate between the two and really give us some insights into who we're looking at. Both of these bacteria we might expect to see growing on our skin. Staphylococcus aureus is one that we may think of as being more likely to be a potential for infection, all right, causing different types of staph infections. Epidermidis, not as much, all right. There are some opportunities for epidermidis to cause some infection, but for the most part, we think of it really more as a harmless commensal, just an inhabitant on the skin taking up space, all right? But there are some opportunities, all right? And oftentimes, epidermidis might be more of a concern when we think about individuals with catheters and it may be a contaminant that gets brought into the body that in turn causes some infection. So here we can see with the micrograph some of the Staphylococcus, the clustered appearance with these guys. You also might perform a catalase test, and you could see either of the staphylococci bubbling because they've got catalase activity, and streptococcus that we may be wondering wouldn't. They're catalase negative, all right? But truly, these guys would be growing on MSA, and the streptococcus wouldn't grow there at all, all right? So this image, and I should have, as I started this, I should have gave a disclaimer. There are some potential images in here that might be a little bit graphic. This one, potential issue. There's a couple more down the road that are maybe a little more disturbing. So keep that in mind. Furuncles, these are boils, and carbuncles, they are pus-filled lesions. They're more pronounced, more aggressive than a furuncle. They're ultimately multiple furuncles combining together to give you a carbuncle, all right? Both kind of interesting names, I think, all right? So here we can see this carbuncle. The bed sore, all right, is really what we're looking at, and Staphylococcus is a good culprit for causing these issues, and we can see a lot of pus within this lesion. And again, a lot of that, the result of cells, white blood cells, the dead bacteria, maybe some living bacteria within there as well, all right? And some of our own cells. This image, always a bit disturbing when you throw little kids into the mix, but we need to think about some of this stuff as well, because there's definitely some potentials. So this is a newborn with what we call scalded skin syndrome, and it is something that can be systemic, completely covering the body of this newborn, and the skin sloughs off. There's some exfoliating toxins that Staphylococcus harbors that makes it slough off in these big patches. And as the name implies, it really kind of looks as if they were dipped in like a big pot of boiling water, and the skin is just kind of peeling away. Disturbing for sure. Impetigo is, well, technically with impetigo, there's multiple bacteria, but Staphylococcus, a main player, and Streptococcus participates in this as well. So Staph aureus and Streptococcus pyogenes are the two participants in infections with impetigo. This is something that is really pretty contagious, something that's pretty common occurrence in children or adolescents, and lending to potentials when we think like school-age children, with it being pretty contagious, for the potential for it to spread pretty readily. All right, it's oftentimes something that we see around the face, but it can present elsewhere. So we saw some aureus. Here's some Streptococcus pyogenes. And looking at them under a microscope, we oftentimes see these big long chains, which are pretty characteristic, all right? There are some things that may lend to a bit of confusion. As I look at this other glob of cocci right here, it may make you kind of wonder, well, is that clustered? Is it just the result of a handful of chains kind of laying down together as you made this smear? That's probably more likely. And in turn, something like a quick catalase test on this culture may clue you into what's really happening, all right? And if there's no bubbles at all, well, we're really just looking at the Streptococcus. But what if we saw both? Maybe what we've got is two organisms in there, and then maybe some further cultivation is needed to truly separate. But if we're talking impetigo, maybe we would expect to see both of these players, all right? This really is supposed to just be Streptococcus pyogenes. But like I said, if we're talking impetigo, maybe we would see both of those. So Streptococcus pyogenes is something that when I think about it, the first thing I think about is strep throat, all right? That's really where I would be thinking about Streptococcus pyogenes, and we will see it again when we move into the digestive tract, right? But it also, like I said, some of these players we will see repeated, all right? It also has potentials to cause some other really pretty serious infections, all right? Some skin infections where we see it making its way through the skin, either through a cut or a wound, something like that, that allows it to make its way in is typically how we think about it causing these problems. So cellulitis is what we see in this first one, ehrlichia, this raised rash, also typically on the face, and the erythema nodosum, lumps or nodules, and this typically in the extremities. This is one that's a bit disturbing, and I'm pretty sure we're seeing the same patient. There it is, same patient. So this also pyogenes, although there are some other culprits that can cause necrotizing fasciitis. Streptococcus pyogenes, this is a flesh-eating bacteria. That's really what we think about with necrotizing fasciitis as it gets in there and starts destroying the fascia. So this massive amount of damage, tissue damage, a lot of the dark is necrotic tissue, dead tissue that in turn, in our next image, is being removed. So surgical debriding, getting rid of all of that. Ultimately, multiple skin grafts are going to be needed to get in there and patch up the removed tissue. And in some of those circumstances, we think about amputation, really to try to deal with it, dependent upon the severity of that infection. Hot tub folliculitis sounds like something fun, but it's not, right? I don't think it's something that you're hoping for, all right? So a red, itchy rash, almost acne-like as we're looking at this, and it's something that we might think about colonizing all over on your body as you're submerged into that nice hot pool. So Pseudomonas aeruginosa is a main player for this. And it likes these warmer types of habitats. It's an environmental bacterium and something that has the potential to cause some pretty big issues. Folliculitis, not something that's super severe, but there are definitely some other problems. Swimmer's ear, also something that could be hot tub worthy. Otis externa, another one that Pseudomonas aeruginosa is a player with, where it gets in and can colonize, causing inflammation of outer ear and ear canal, but on the outside of the eardrum or tympanic membrane. We will think about otis media, an inner or middle ear infection with other players. Typically, those guys, we think about organisms that might make our throats home, and they cause other issues. So Pseudomonas, there's a lot of different things that I think are pretty cool with Pseudomonas and also lend to some of the issues when we think about trying to combat it, all right? So Pseudomonas is a gram-negative bacterium. It produces a capsule layer that lends to it avoiding detection from immune responses. It also is super good at causing biofilm formation, so it can lay down structures upon structures on top of itself and kind of encase it and hide away. So antibiotic therapy can be difficult with these guys because of that biofilm formation, and you might target the outer bit, but inside of it, they're still growing, all right? Pseudomonas aeruginosa can produce a pigment called pyocyanin. It's a greenish pigment. And it can turn the media really to make it look like a lawn of growth. It's bright green as it's growing in there. And there are also some Pseudomonas aeruginosa and a few others that can fluoresce when you expose them to ultraviolet light. They glow in the dark. So a black light can make these guys kind of glow. I had a student in pathogenic microbiology lab where we're looking at all sorts of different organisms. You guys had an unknown that you worked through. In the patho lab, it's lots of unknowns where we look at each body site and you get a pathogen that you try to figure out. I had a student that, Pseudomonas was incorporated into a handful of labs, and he had a little flashlight that had a black light on there, and he'd walk up and shine it at the tubes, and the one that was glowing the littlest bit, he'd grab that one. And after a couple of labs, I'm like, wow, it's weird that you always end up with Pseudomonas, right? And then I saw him up there sampling before he was grabbing his thing. I'm like, what are you doing, right? And like, wait a minute, right? That's not really fair. You shouldn't always be getting that one, right? He's like, and then the unknown isn't unknown anymore, right? He knew, right? Tricky. All right, I mentioned blackheads a minute ago. Here's an image where we could see that normal whitehead, blackhead situation as it progresses. So oxidizing lipids lending to this darker production within there. Maybe a whitehead right there. Anthrax, another one that we will see in a couple of chapters. Cutaneous anthrax is definitely more of a common thing when we think about it, not something that's super common, but it was, and is still potentially when we think about different occupations. Agriculture stuff, maybe, especially if we think ranching. Ranchers that are dealing with livestock, handling the hides of these animals, shearing sheep, things like that, potentially bring you in contact with some of the organism or spores of the organism and may lend to infections. Cutaneous anthrax has been called wool sorter's disease because it definitely is a good environmental pathogen that you might come in contact with. And sheep herders or sheep shearers, whether it's the sheep herder that's doing that shearing or not, would typically get infected on their hands as they were dealing with that stuff. So you can see this necrotic tissue, this black eschar, that's the result of dead tissue from this bacteria getting in there. This is an image of it growing on a blood agar plate, and the Bacillus anthracis is a bacterium that can destroy it, although we can't really see that happening here. If we were to hold the plate up so we could see some light shining through there, where the bacteria is growing, it's completely clear, and where it's not, you can't see through it, all right? So they've destroyed all of those red cells. We call that beta hemolysis or beta hemolytic. And that gives it a potential to be more dangerous, more virulent, or potential to cause disease enhanced. So as far as the bacteria of the skin, a plethora of these, many we have seen some images with, a lot of players, all right? Staph aureus, Pseudomonas, some pyogenes up in here. We showed the acne, but didn't actually say who the culprit is with this. Propionibacterium acnes is the culprit that causes acne. And with a name like acnes, it makes sense, right? Propionibacterium is a potential inhabitant of the skin and lending to the conditions in adolescence where we may see the habitat shifting and becoming more suitable to these guys. we can see them starting to thrive and maybe overgrow, lending to the issues of acne. All right. There are some with lower levels of this and don't really see big issues. All right. And you could think back to, you know, maybe high school or middle school days, whenever it first starts really kind of plaguing you. Maybe you battled with it, maybe not so much, right? And it really kind of depends on what do you have really as a colonizer, all right? So not transmissible. We don't think about this something that you're sharing, right? It's just the normal microbiota getting into those clogged pores, lending to issues, all right? So all sorts of other things. Wound infections, we didn't see this, but Pseudomonas, the glow in the dark guy, is a big player with some of these problems. Burn patients or patients with some severe wounds, if Pseudomonas can get in and colonize, it can lend to some serious issues with the fact that it forms biofilms and is pretty resistant to antibiotics. It can be a very serious infection. So back to some eye stuff, another ghost, right? This is where it all, I was like, wait a minute, right? So conjunctivitis, this is bacterial bit. There's also viral possibilities for conjunctivitis, but the kicker is when it's bacterial, it's a purulent discharge. You get a lot of pus, you get organism in there that is very different when we think about a viral one that's really just more watery eyes than pussy, all right? So yellow, green, or white discharge, the potential for the eyes to kind of be sealed shut. This is pink eye, all right, conjunctivitis, all right? And typically we think about, lots of times when we think about pink eye, we think about bacteria, but like I said, there can be some viral culprits, and it really kind of depends on how we're presenting, all right? And if we've got all of this discharge, we're thinking bacterial as the culprit. This image, this eye's sealed shut as well, but this is different. This is gonococcal ophthalmia neonatorum. And so basically, the child was infected with gonorrhea in transit through the birth canal and causes these issues. And if not dealt with, it results in blindness. So every child, at least in the US, born in a hospital, all right, they have to treat them even if the mother has a clean bill of health, which the majority of them do, right? They don't have gonorrhea, but they treat them all because you want to prevent this. And it's just better safe than sorry, all right? So the addition of some antibiotics helps to ensure that if they did come in contact in transit through the birth canal, this doesn't result. Trachoma, another one that we need treatment with antibiotics. Here we can see trichiasis, where the eyelashes and they're basically flipped around. Another that has the potential to lend to blindness. This is another sexually transmitted infection. So chlamydia, trachomitis is the one that's the culprit for this, all right? So bacteria infections of the eye. With our conjunctivitis, Haemophilus influenzae is one of the main players when we think about it causing pink eye. It's truly the one we focus on, all right? So also something that's very easily transmitted, right? For the keratitis, as far as bacteria go, Staph epi and Pseudomonas aeruginosa are some potentials with that. Chlamydia and Neisseria for neonatal conjunctivitis, and the potential for that trachoma as we see it again, right? And this would be a chronic conjunctivitis lending to the trichiasis as a result of that. All right, shifting. We're moving at a pretty good pace. Warts, there are all sorts of different potentials when we think about these players on our body. Plantar warts on a toe, this filiform one on the eyelid, all sorts of different potentials with this. And we are transitioned as we're moving in here into some viral things. So papillomavirus for warts. Here we are looking at a cold sore, herpes simplex virus type 1. Typically what we think about on the face. Type 2, typically what we think about in the genital region. However, they can be flip-flopped, all right? So we'll see the other later, all right? So cold sore, characteristic with that. There are numerous viral infections that we think about on the skin with some rash-like lesions that appear. And a lot of these we think about as some childhood illnesses, things that are relatively common for some little kids to get. And a lot of the time, it's something that you you let it run its course. There's not really much you can do about it. Potentially trying to treat fevers, but otherwise, there's maybe not a lot that you do for it. So roseola is a mild infection, pretty common in little kids. Cold-like symptoms start off and then rashes. Pink patchy rash starts on the trunk and then moves to the extremities. And we can see some fever associated with it. This kid, it makes me laugh every time. He doesn't seem upset at all. It's like he's just laying there like, hey ladies, right? What's up, right? And he's got rash all over, right? And really pretty rosy cheeks. So that's the sort of slapped cheek appearance that's characteristic of fifth disease, which they say is the fifth in a series of viral rash-like infections that you kind of expect, right? Roseola being one of them. We'll see some others. And I'm like, well, what happened to number 4? Where are you? So handfuls as we think viral stuff. So the fifth, this is a parvovirus. There are numerous viral culprits and numerous types of parvoviruses. Some of you that are pet owners are like, isn't that something I vaccinated my dog for? Different, but yes, right? So cold-like symptoms, rash, very contagious when we think about it. And again, little kids. The herpes keratitis with simplex 1. There are all sorts of potentials with this inflammation of the cornea and potential for blindness. Oral herpes, also type 1. The papillomas, roseola, as we move down here. A couple of different herpes viruses can be the culprits for roseola, herpes 6 or 7. And then, like I said, oftentimes with our conjunctivitis, the purulent discharge indicates some Haemophilus going on, but a clear, watery discharge makes us think viral stuff. So adenoviruses, and there are some others, but these are adenoviruses are more common with that. So it's something that we might think about, watery eyes with a cold, right? But not all of this purulent discharge, all right? And it is contagious when we think about contact with that. All right, fungal stuff, so much. Taenias, we talked about and showed our ringworm before, and these taenias were once initially thought to be a worm, and taenia means worm, but they are not worms. It is a type of fungus, all right? But they all have some sort of tinea associated with it, all right? And oftentimes named by where on your body we may expect to see it, all right? So, and I know there's a table in here that goes through and lists off more of these guys. Tinea barbae is barber's itch, so you typically see it on the face where you might be shaving, and you can see the fungal infection in this individual, pretty aggressive, I think. Tinea pedis is athlete's foot, something that is really pretty common. And you can go to the store and pick up some athlete's foot spray over the counter. You don't need to go to the doctor to deal with that stuff, although you may think you do, right? And then Tinea corporis, this is ringworm, and there are handfuls of different species of fungi. Trichophyton, one of them that we've got here. Trichophyton, epidermophyton, and microsporium are three genera that are culprits in all of these types of tinea infections. And it just kind of depends on the respective one that we might be seeing, and also potentially where on your body. When we grow these guys up, and this is a sabarode plate, like I mentioned as we started this, something that would let some fungus grow, all right? So sabarode agar allows for the funguses Trichophyton rubrum, and it is a culprit for some of these infections that we may see, all right? Manifesting like this, but when swabbed and plated, you get this filamentous fungi growing on the plate, all right? Mold, right? You don't want to think about it like that, like, holy crap, I'm molding, right? That's not so good, right? What do you do with that moldy piece of fruit when you see it in the fruit basket? You pitch that sucker out, right? That's bad news, right? We want to get rid of this stuff, right? So we can see it, and here we're only showing one image, but when we look at fungi, we oftentimes look at the top surface and the underside of the plate, because they can be very different looking, and we can use that, potentially use that to identify them taxonomically based off of some of the maybe pigment that we see on their underside, and different morphologies lending to that as well. So here is another fungus, Aspergillus, and it can be like some black mold that you may see in your house. Sick building syndrome sometimes is some fungi, other times it might be like different chemical pollutants within there, but Aspergillus can be a culprit, all right? What we're seeing in this patient over here is called secondary cutaneous aspergillosis. And what we mean by that is this is a result of an infection that has disseminated, all right? So it started off with the primary aspergillosis, and that would be in the lungs. Inhaling these spores of this mold, it converts into a mold and grows within the respiratory tract, and then can potentially disseminate. As it moves to the skin, we can see these ulcerated lesions that result. So secondary aspergillosis is the result of it disseminating, all right? We could also see cutaneous aspergillosis that is a primary infection that would be the result of this fungus getting inoculated into the skin through a wound. And that would result in it growing at that body site without the dissemination, all right? That would be a primary, all right? But usually when we think about something like this, it's the result of a different infection, a lung infection that has progressed to this, all right? Definitely more serious as we have moved throughout the body and then start manifesting on the surface. So Candida albicans, there are some other species with these as well. These are types of yeasts. Here we can see a sabarode plate with the yeasts growing on there. yeasts look very different than the molds that we saw, those tenias that were more kind of fuzzy like. These are more kind of creamy colored, almost bacteria looking cultures compared to the molds, the tenias that we saw. So here's a cutaneous candidiasis. All of these circulate or situations, we think sort of an opportunistic situation where immunity is depleted or microbiome has been depleted with antibiotics, something that sets the stage to maybe lending to these guys taking hold, right? This on the skin, here's a nail infection. It can be some of our fungi, and it also can be some candida, all right, that may result in this, all right? Handfuls of different players that can cause some of these infections, right? And I started with this, the image of those yeast cells growing on there. So sporothrix we saw before, that image isn't in here, but remember that individual's arm with those nasty lesions on there that are deeper into the dermis, not like our tenias that are in the epidermis region. This one's more deep, all right? Cutaneous candidiasis, we'll see it repeated later. And then again, with the cutaneous bit, our aspergillosis, here we can see primary getting directly into the wound or moving from the respiratory tract, as I said. It can be something that we might see as a hospital-acquired or nosocomial infection as well. And in that circumstance, we would think about pulmonary disseminating to a secondary site. Okay, just a couple left. We're about done with this. So to some parasites, amoebas. Acanthamoeba is an amoeba that likes colder water. We will see some other amoeba a little later. And it's something that has the potential to cause infection in the eye. Contact lens wearers potentially can get infected with this, and there have been issues with some lens solution that wasn't sterilized properly that caused some problems. There's also issues with people that prepare their own that may inoculated into you. So this shows more than just the eye involvement, because we're looking at an image from the CDC that shows multiple things going on, all right? But there are potentials for the eye involvement. There are other issues that we could think about with meningitis or other problems. So here we can see the cyst stage of our amoeba, and then the vegetative or trophozoite stage. Acanthamoeba has spiky or sharp little pseudopods, and other amoeba more rounded, blunt-like pseudopods. Here's some keratitis. This is a stain that's been added that allows us to see the damage to the conjunctiva as a result of the infection with this. So Loa loa is the eye worm. It is a roundworm or a nematode that gets into the eye. Here we can see an image with a little bit of the worm right within there. Very complex life cycle, but here we've got a deer fly taking a blood meal. It infects us with the parasite and then causing multiple issues, but migrating to the eye is a common occurrence, and blindness as a result of this, definitely a concern. And I'm not going to go through all of the life cycle with it. I sure want to, but I'm not. This one, not in the chapter, but it made me stop and wonder, what the heck? How can you talk about Loa loa, the eye worm, and not talk about river blindness in the same chapter? Come on, right? Onchocerca volvulus is a crazy parasite. It's another nematode or roundworm. It's transmitted by a different fly, a black fly, The fly takes a blood meal, we get infected with the parasite, and it causes lots of problems. We can see some skin manifestations, but it also gets into the eye, and it's the juveniles, the filarial worms, these little juvenile worms make their way up into the eye, destroying the retina and lending to blindness, right? There are some villages in Africa where river blindness is super common. And the adults, almost every single one of them are blind as a result of the infection. The children aren't blind yet, but they're infected. It takes a long time for blindness to truly set in, right? And the children lead the adults down to the water so they can fill up their jugs of water to bring back to the village. And they basically lead them all down there because they can't see where they're going, right? Crazy. All right. That's the end of that. Farewell. We can do one chapter like this every time. It's going to be smooth sailing. All right.